The resting position we should always think of as the position to what? That's our test position, right? We want, when we assess how much motion is there at the capsule for any joint, we want it to fall to the resting position. So at the tibiofemoral joint, that's 25 degrees of flexion, okay? And I'm gonna demonstrate to you how we can do that, but it is common practice at the knee to move away from the rest position a lot of the time to do the assessments, and so I'll show you that way as well, okay? The reason why we move away from the rest position is because it can be really challenging to do a good assessment in that 25 degrees of motion. Okay? The joint mobility assessment at 90 degrees of knee flexion. That is a deviation from what we typically discuss in this class. That's into the rule, all right? But if I was going to be a stickler for my 25 degrees, what I'm going to have to do is I'm going to have to bolster the knee. For the anterior glide, I'm going to bring my hands to the front. I bring my whole hand behind the back, so I'm right on the posterior tibia as best as I can. My other hand is actually trying to palpate the knee joint line, the tibiofemoral joint, so I can feel for how much it moves, okay? And now, what is my direction of movement? I'm going to do this assessment. What's the direction? Parallel to the joint plane. And the joint plane, I got to look at that tibia. I got to look at that joint. And I can just do the anterior assessment, okay, by pulling the knee anterior, the tibia anterior, feeling with my left hand, my fingers, just how much motion he has, okay? What I like to do, though, is I like to place my hand underneath the femur in this case, just to give it some stability, because as you press backwards, what's going to happen? That's where you see how I'm extending his knees? Actually, I'm creating osteokinematic motion at his knee when I'm trying to do a posterior glide. I don't want to engage that, right? And again, my direction is parallel with the tibia. So I just get my arm, I can get my forearm right in line with that, and I can start to feel just how much backward motion he's getting. That's one side over the other, okay? But it's doable. For the anterior glide, not much changes, but if I'm going to assess his medial anterior glide, instead of placing my hand directly behind the tibia, I move my hand out so the second metacarpal head is going to engage the posterior tibia. My palpating finger is going to be on that medial side joint line, so I might need to look in the same direction, just trying to rotate that tibia and see how much does that medial side come forward. The lateral side, it's going to be, I can't get too far under and push forward that way. I'm going to have to switch my hand. Okay? So what I do actually is I would come to this side now. My right hand's going to be my palpating hand, my palpating finger. See how much, get right in that joint line. And now again, second head of the metacarpal, posterior tibia. And I'm going to see just how much anterior translation his lateral side gets. Though instead of my metacarpal, I just use my thenar eminence to try to apply that force. But this is where this is where it gets really icky. I don't know if I'm getting really good information. Okay? Same thing on this side. I switch sides. My thenar eminence is over the medial tibia, trying to see how much posterior glide into the medial tibia go through. So what I'm really doing is I'm rotating his tibia, and I'm doing all. You can stabilize the foot and the leg by just sitting on the foot, just to keep it down, okay? And so now what I can do is my thumbs can be right on the joint line, and pulling together, I can do an anterior assessment. I can do the posterior assessment, okay? I can start to look at the rotational assessments. What I can do is I can pre-rotate the tibia. So I'm going to externally rotate the tibia some, restabilize that, and then I can, from the lateral side, look at the posterior rotation. From the medial side, I can look at the anterior rotation. Okay? Then what I can do is I can set the tibia the other way. I can internally rotate the tibia some. Set the tibia in some internal rotation and kind of, so that way the tail crew joint doesn't become a barrier to that motion. And you can get a good assessment for how much it's moving overall. This is another place where you can do your assessments again. And later on we can learn, you can do your mobilizations from here as well. You're going to have to cradle the weight of the limb, okay? But if I wanted to look at a posterior glide, I can just be here with my hands. Again, my fingers are assessing that, and I can just go with that plane, posterior glide. If I want to do an anterior glide, just make sure you stabilize the femur and get a feel for that anterior glide.
Are you back in the 25-degree position?
Yeah, this is about 25 degrees here, okay? And then I can look at my rotational pieces. For me, it's a little harder to do in this position, but I can get my hand more just on this medial side. If I'm going to do that posterior glide, I can look at the posterior glide on the medial side. Okay. Conversely, I can just look at the anterior glide on the medial side. Also, changes the plane of the motion that you're going to look at. Okay. So the 4 motions we're going to assess for is the superior glide, the inferior glide, then the medial glide, and the lateral glide. And all of them you can just do sitting right where you are. Again, this is just an assessment for how far is it going to inferiorly glide, how much is it going to superiorly glide, and then we can do the medial and the lateral glide, and we can just do that with our fingers, okay? So if I'm going to do the superior glide, the way I always assess that is I find the inferior pole of the patella, and I'll make a V with my fingers, or even it might even just be my entire thenar eminence there, just kind of between my first and second metacarpal, and just place the patella right into that V. Okay. Then what I can do with my other hand, with these fingers, is I get right in the patellofemoral joint line. So I'm feeling just behind the patella, right in that joint itself, okay? And then I get a feel for how much does the patella glide superiorly in relation to my hand, in relation to my fingers. And we said superior glide is associated with which motion? Extension. So his knee's already in the 0 position. So sometimes in a superior glide, you may not feel all that much, which is okay, because it's already nearly at that end of range anyway, but you should feel some. Inferior glide, again, I make the same V, just now I'm on the superior patella. My other hand is just on the medial lateral joint itself, and then I assess for how much inferior gliding there is. Okay? How's that feel? Remember, we're at the patellofemoral joint now, not the tibiofemoral joint. We're near the closed pack position for the tibiofemoral joint, so I probably wouldn't expect a lot of anterior posterior gliding to go on here. Just medial glide, same thing. So now what I'm doing is I'll just use my thumbs on this side and then my fingers here for palpating the amount of motion that's happening, and I get an appreciation for just how much medial gliding there is going on there, which is a good amount. Last is going to be the lateral glide. Now the lateral glide you want to be careful of. You definitely want to take it easy with that and how much force you're putting through and what's the reasoning behind that. Yeah, so it's the most commonly dislocated position for the patella. When we're assessing joint play, we think of Count-and-Born grades 1, 2s, and 3s. We're talking about a Count-and-Born grade 2. What we're doing is we're taking that rope to its very end and saying, that's it, the rope doesn't stretch any more than that. That's the end of 2. That's how much motion there is. But the other thing you can do even in your assessment is assess for what does that end feel like. You can start to push into it and start to feel that. And so if it feels very firm capsular to you, then you start to say to yourself, okay, you know, I've definitely engaged that capsule, that barrier, and that's what I'm feeling. So now if it was, even in individuals patellofemoral, they always tend to track laterally when you look at your movement assessments and all that. So if I was to ask, Riyadh, do a quad set for me, just try to straighten out your quadriceps, I start to look at, you know, his kneecap, his patella should just glide superiorly, straight superior. That's what the textbooks and everything say. But if his is going superior and laterally, is his vastus lateralis over dominating? And so then he's got this tracking. So then what you expect to see in people is that lateral glide, that lateral superior glide to be very easy and a lot of motion. And then when you try to go medial, it feels very tight and restricted. So in those individuals, you might want to do a mobilization that way. And then you might even want to do taping when you're taping them over that way. Direction of your movement is posterior medial, okay, and anterior lateral. Those are going to be the two directions that we want to assess that in. The one anatomical structure you want to be cognizant of that's there is the fibular nerve, especially posteriorly. So when you're doing that anterior glide, you're going to want to assess your patient and make sure that you're not irritating that nerve at all, okay? But anterior medial, so this technique you really can just kind of use a pincer grip around the fibula, okay? If you want, you can do a palpating finger, and then I can do the posterior medial direction. Now what I might play with is just how medial, the direction of medial, till I feel like I get the most movement. Whatever direction I feel like I'm getting the most movement out of that fibula, that's going to be where I want to do my assessment. Okay? So at first I was kind of almost pushing too medial. I felt like I was just compressing her fibula into her tibia. So instead of pushing in that way, I started to come out this way, and then I started to feel like it moved a lot more. Then I overcompensated for that. I did more straight posterior, but I feel like I didn't move as much. So you got to find that place where you say, oh, there's where my patient's fibula is moving. Okay? Anterior glide. Then once I've got that direction there, I just do the exact opposite direction out just to feel for how much it moves when I pull it out. Is that okay?
Mm-hmm.
Are you doing that same like sort of
Some people have a lot. Hers is not so bad. Hers are actually not so bad. I've had people where it just